Okay, I guess we can get started. It's 2:30. So thank you all for staying here, and hopefully we're almost done. Okay, so I'm going to be talking about radiotherapeutic management of esophageal cancer. So it's going to be a didactic and brief, but feel free to interrupt me with any questions as we go along. Okay. So just just kind of a brief overview of the standard management. Of course, as you know, the global geographic distribution of squamous versus adeno is quite different. Obviously, mostly here in the eastern part of the Earth, actually in the hemispheres, are usually 95% squamous cell carcinomas, and in the West is 75% are adenocarcinoma. The management is somewhat similar in a sense. For squamous, of course, even the early stage disease, it's surgery is primarily for patients with early to mid stage cancers, and adjuvant chemotherapy or radiation is often used. But in more locally advanced disease patients, preoperative chemoradiation followed by nivolumab or perioperative chemotherapy, especially in Japan, is all still used. And in patients with unresectable disease, definitive chemoradiation is the standard of care. For adenocarcinoma, local excision as well for early stage disease. But of course, now there's quite a bit of controversies between what is best, preoperative chemoradiation followed by nivolumab or perioperative chemotherapy because of the recent studies. And of course, patient with unresectable disease, definitive chemoradiation is the current standard of care. I'm going to go over all the evidence, of course, and then have a discussion in terms of what would be optimal therapy for these patients. And so after diagnosis, of course, staging, various staging workup you need to do for the appropriate staging of these patients, except for the early stage disease here, where local excision is still used. Most of my focus will be on here, in patients with locally advanced disease. And of course, in patients with locally advanced disease, you often determine whether they're surgical candidates or not. And there's all these. This is in terms of the management of these patients, either preoperative chemoradiation, which was the standard until just recently. Perioperative chemotherapy is also another standard. Patient with unresectable disease, of course, definitive chemoradiation is the standard. Patient with stage 4 disease, of course, it's chemotherapy or chemoimmunotherapy if they have PD-L1 high, or PD-L1 actually any expression PD-L1, and radiation is really more for palliation in that setting. All right. The management of this is actually broken up into whether patients are resectable or unresectable, and I'm going to spend the majority of my talk on patients with resectable disease because this is the most controversial area. However, if you actually consider a patient who are resectable, surgery alone is still considered the single best modality for curative management. So if you're going to do one treatment, you're going to select one treatment, doing surgery up front is still the most curative management for these patients because 5-year survival is about 30%. If you consider all the other chemotherapy, obviously alone is not curative. Radiation alone is not curative. Even chemoradiation, 5-year survival does not beat surgery alone. So if you can choose one treatment. But of course, we know surgery alone by itself still are not optimal. Patients still do die from local recurrence. Actually the recurrence rate and the control rate to local control is still worse with surgery alone. Therefore, there's been, of course, the effort trying to improve upon surgery, and therefore the use of preoperative therapy and the need for preoperative therapy. Chemoradiation, of course, and of course this is in the U.S. at least, it's been utilized. Preoperative chemoradiation has been tested for many years now. And the reason why we started with preoperative chemoradiation is because there's been a trial for preoperative chemotherapy called the Kelsenadol phase 3 randomized trial, and that was negative compared to surgery alone. So therefore, at least in the United States, preoperative chemotherapy was not used because of the negative phase 3 trial. So a lot of the effort has been devoted to preoperative chemoradiation, trying to improve upon surgery alone. However, before the cross trial, it was still very controversial because of the data. Actually, the data is out there. The first one actually is the Walsh et al. This is actually from Ireland, right? The Irish study, which is only 113 patients. This was a positive trial showing that preoperative chemoradiation improves over surgery alone. However, there was a lot of controversies because the arm for surgery was very poor in terms of survival. So if you actually compare to preoperative chemoradiation versus surgery alone, this was significantly better. However, because of the outcomes of the surgery alone, many surgeons did not believe this trial, the results of this trial. And then Joe Tepper actually did a phase 3 randomized trial. This was supposed to be about a 450 patient study, but they ended with only 56 patients because of the poor accrual. They could not accrue to this study. And however, they did demonstrate a benefit of preoperative chemoradiation compared to surgery, but because of the small number of patients, and this study was shut down due to poor accrual. Also, no one really believed this particular study. There were other studies, Erba et al. This is from Michigan. It's a single institutional study. It was only 100 patients. They did show a trend, but however, it was not statistically significant to benefit of preoperative chemoradiation. And there were other studies that are actually mostly in squamous cell. That was and also in Australia, there was no difference, or no difference in outcome with preoperative chemoradiation. So that's why this is actually very controversial in terms of the incorporation of the benefit of adding chemoradiation before surgery. And that's why the cross trial was so significant when the results came out. And of course, this was done in the Netherlands, demonstrating, and it was the first actually high quality study that actually completed. And however, there was still somewhat unconventional because the chemotherapy was unconventional at that time. We were using 5-FU and cisplatin as the standard chemoradiation regimen. However, in this particular Dutch study, it was carbotaxol, so that's not standard. Also, the dose of radiation was also not standard. They used a lower dose of radiation of 41.4 gray. Our dose, of course, in the United States was 50 gray, so it's a little bit lower than what we typically we did in the U.S. However, they did, of course, show the benefit of preoperative chemoradiation. The R0 resection was better if you incorporate preoperative chemoradiation compared to surgery alone. Path complete response, of course, was significantly better. It was actually 29% of complete response, complete pathological response, compared to, of course, obviously surgery alone. There was no response, of course. And however, if you actually look at the response based on histology, 23% for adenocarcinoma, much better for patients with squamous cell carcinoma with incorporating chemoradiation. Of course, the primary endpoint is overall survival, showing a benefit of incorporating preoperative chemoradiation compared to surgery alone. With longer, this is a 10-year outcome of the cross trial, showing that sustained benefit of survival in patients with preoperative chemoradiation compared to surgery alone. You can see here, of course, this benefit extended mostly to squamous cell carcinoma. And so squamous cell carcinoma patients did much better using this regimen compared to adenocarcinoma. However, both of these groups benefit compared to surgery alone. The separation, of course, you see here is because of biology. Squamous cell carcinoma patients tend to respond better to chemoradiation, and therefore you separate from this adenocarcinoma group. But of course, you don't see that biological benefit in a patient who receives surgery alone. That's why there's no separation. Of course, in China, they want to repeat this because of the benefit of squamous cell carcinoma. So this is actually mostly done in Guangzhou and kind of southern China area. They randomized 451 patients, all in squamous cell carcinoma patients, showing that, of course, path CR rate was what you expect, much higher than what you expect for adenocarcinoma patients. There was better resectability, and of course, overall survival also benefited for incorporating preoperative chemoradiation compared to surgery alone. So now, how about neoadjuvant chemotherapy instead of chemoradiation? Well, this was actually the study that I talked about, Kelsen et al., intergroup 0113. This is a negative study. And that's the reason why in the US, at least at that time, preoperative chemotherapy was not used because of this negative study. And therefore, all the investment in trials and the time was invested in chemoradiation. So this was a negative trial. It's a phase 3 randomized trial showing a slightly improved path CR rate, only 2.5% of incorporating chemotherapy. But the most important thing is no difference in overall survival adding chemotherapy to surgery. And therefore, this was not a standard of care. However, in the UK, this is in England now. Of course, they did a much larger study. Instead of Kelsen et al. With 400 some odd patients, this is 800 patients, double the number of patients. And of course, they used only preoperative chemotherapy of 2 cycles cisplatin 5-FU versus surgery alone, showing a significant benefit of survival in patients adding chemotherapy to surgery. So that's why in the UK, they leave out radiation. And in the UK, because of the MRC study, showing the benefit of adding preoperative chemotherapy to surgery versus surgery alone. The MAGIC trial was another MRC UK study. However, this is mostly in gastric cancer. However, 25% of these patients had esophageal cancer. They used a little bit different chemotherapy. Instead of cisplatin 5-FU, they also add epirubicin, so it's a 3 chemotherapy regimen. Very toxic, epirubicin combination chemotherapy. And nowadays, we don't use epirubicin because it's extremely toxic. And there's another phase 3 trial showing really no benefit of epirubicin compared to cisplatin 5-FU. Therefore, it's fell out of favor. But at least the MAGIC trial incorporated epirubicin-based chemotherapy. So they did 3 cycles pre and 3 cycles post-surgery versus surgery alone, again, showing a benefit of perioperative chemotherapy compared to surgery alone. So, and that's the reason why, because of the MRC study, OE2, as well as the MAGIC trial, preoperative chemotherapy was their standard of care versus chemoradiation. So FLOT, of course, this is actually now, instead of those chemotherapies, cisplatin-based and 5FU-based chemotherapy, the FLOT is actually a 3 chemotherapy regimen study where they incorporate docetaxel along with platinum-based chemotherapy and 5FU. So this is a gastric or G-junction patients with locally advanced disease, all medically inoperable, and they were randomized to FLOT perioperatively before resection and post-resection versus the standard of care, which is ECF, ECX, and eventually just CF. Showing, of course, the benefit of FLOT for 4 cycles perioperative chemo compared to the standard of care. So that's the reason why this is now, of course, now in the FLOT era, they repeated the study. Now, is doing which one's better, right? Preoperative chemoradiation with cross versus FLOT. So there's a number of studies now that has been published. So the yellow highlighted ones are the ones that's published, and I'll talk about these studies now. This was the race studies still not yet published. So I'm going to talk about the first one, which is NeoAges. Okay, so NeoAges was just published a couple years ago. So this is initially was a study that was powered to show superiority across preoperative chemoradiation versus perioperative chemotherapy. However, because of the pandemic, this was shut down in 2020 because of the pandemic. So instead of 540 patients, they downgraded 377 patients. However, in showing only powered to show actually non-inferiority. So it became a non-inferiority study versus superiority study. So what they found, okay, so you see, of course, differences in the toxicity is a little bit different between the two studies. I mean, the two arms, in that, of course, the patient who received chemotherapy, they have a little bit difference in toxicity to particularly myeloid suppression, neutropenia. Of course, patients who receive chemoradiation, there's slight increases in odynophagia and nausea, et cetera. What you expect, of course, the patient who receive chemoradiation, there's a better response rate. So you see there's greater downstaging in patients who receive chemoradiation compared to chemotherapy. Both the primary disease as well as nodal downstaging and tumor response. That's what you expect, right? Chemoradiation should improve tumor downstaging, okay? But what's important is actually no differences. So this was a non-inferior. So that means preoperative chemotherapy was non-inferior to chemoradiation, no difference in overall survival, and no difference in disease-free survival between the two arms. So Top Gear. So this is actually a trial that was actually just published late last year. So this is mostly in gastric cancer. Approximately a quarter of the patients had esophageal cancer. So the patients were randomized to ECF, ECX times 3 surgery versus chemotherapy induction, chemoradiation, preoperative chemoradiation with 45 gray surgery, and then perioperative and postoperative chemotherapy. Again, showing no differences of actually comparing chemotherapy versus chemoradiation, right, in both overall survival as well as progression-free survival. Now, the ESOPEC, okay, ESOPEC was of course, this is just came out in New England Journal of Medicine about a month and a half ago. So this is, of course, I'm going to just show slides from the ASCO presentation because essentially it's the same data that's actually presented in New England Journal of Medicine paper. So this is essentially the schema. Patients were randomized with locally advanced esophageal cancer. They were randomized to cross, which is 41.4 gray carbotaxol, followed by surgery, versus FLOT. So this is perioperative chemotherapy times 4 with FLOT times 4, surgery versus postoperative chemotherapy. If you actually look at the two groups, no differences. So these two groups are well balanced in terms of actually age, sex, as well as actually tumor staging. What's interesting, and this is very surprising, if you actually look at the path results for these two groups of patients, the cross results, if you look at path complete response, is only 10%, which, of course, as you expected, if you saw from the previous presentations and all the data up to this point, preoperative chemoradiation, the path complete response rate typically is about 25%. So therefore, the path complete response rate is much, much lower than historical controls, including all the randomized trials that we know. Whereas, of course, this 16% is exactly what you expect because even the FLOT4 study it was about 16% path complete response. So of course, the rate of complete response in the cross group was significantly lower and worse for the ESOPEC trial. What's of course most surprising, and maybe not surprising, but I guess, is that the benefit, that the FLOT did much better. So therefore, if you actually look at the progression-free survival, they exceeded the cross arm. And so you can see here in both groups that the 3-year and 5-year progression-free survival time was superior in the FLOT population group compared to the cross. And that also benefited in overall survival, that there was a significant improvement in overall survival in the FLOT group compared to cross. What is actually, but however, this is one of the discussion slides from Karen Goodman at the ASCO. So you can see here is actually what was the limitation of the ESOPEC study is that the compliance rate in the cross arm was significantly worse. That means 68%, only about 32% of these patients did not complete even the radiation. So the compliance of the cross was only 68%, much higher compliance on the FLOT population. Of course, as you all can see, that the path CR rate is 10%. You never see typically chemoradiation have worse path complete response to chemotherapy. So this is a very surprising results that we have never seen. So the key limitation is that, of course, the worst compliance in the chemoradiation group, the poorest complete response we've ever seen in any contemporary trials, and of course, this non-standard control arm, because actually what we know, of course, up to this point, right, is that the current standard for chemoradiation is not cross, is actually cross followed by nivolumab. That's the current standard of care. In the ESOPEC study, the control arm was not, it was just cross without the nivolumab. So therefore, the control arm is already worse and not standard of care. So that's a problem. Another thing actually I left out is that if you actually look at this specifically in the paper, in the ESOPEC paper, if you look at the protocol, it allows both 3D conformal radiation and IMRT. However, if you actually look at the actual methods, no patients receive IMRT. Every patient received 3D conformal radiation, and there was no radiation compliance. There actually no radiation central review. So you don't know. Of course, this is all done in Germany, right? ESOPEC was a German trial. So you don't know in terms of even the quality of the radiation. And we know the radiation quality, particularly the use of 3D, is just much, much toxic, including higher mortality rate just with radiation alone compared to even IMRT. Not even talking about protons here, so just even IMRT comparison. So we know that actually the radiation quality is much, much worse in this particular study. And that actually may potentially also impact the results of this study. So the control arm, of course, that I talked about, really should be this, CheckMate 577, right? Which is actually in patients who receive cross regimen. In this particular study, in CheckMate 577, patient had completed chemoradiation, and a patient with any residual disease, which is about 70% of the patient with residual disease, will actually be randomized 2-to-1 randomization to nivolumab versus placebo. Disease-free survival is the primary endpoint. And of course, this is a positive trial showing that actually incorporating nivolumab after chemoradiation in surgery, that there was a significant disease-free survival benefit incorporating adjuvant nivolumab compared to placebo. Suggesting, of course, that if you improve systemic response, then of course you improve the potentially overall survival for these patients. And this was not incorporating the control arm of the ESOPEC. We know actually that immunotherapy is going to potentially impact esophageal cancers, and therefore there's been a race trying to develop this in esophageal cancers. If you can see here, this is all the number of trials that are actually trying to incorporate immunotherapy to esophageal cancer. You can see here most of these are squamous cell carcinoma patients, and most of these studies done in China, actually. So they're incorporating either their own PD-1, PD-L1 drugs, along with either neoadjuvantly or definitively for squamous cell esophageal cancer patients. There's only actually a few of these studies actually done in the U.S., particularly the ECOG Akron 2174, which is actually for adenocarcinoma patients, asking the question whether adding immunotherapy will benefit these patients, particularly with concurrent chemoradiation. So this is the 2174 study, which is actually a patient with esophageal cancer that were randomized to concurrent nivolumab with chemoradiation versus just chemoradiation alone. So this is a cross regimen. But it's a two-step randomization. They randomized the first cohort, which is concurrent nivolumab with chemoradiation. They had surgery, followed by additional randomization to either nivolumab alone, which of course the checkmate 577 regimen, versus adding ipilimumab and nivolumab. Asking the question whether adding CTLA-4 targeting will benefit these patients. So for the first randomization, the primary endpoint is looking at path complete response, whether adding nivolumab will improve path complete response compared to just chemoradiation alone. So this was actually not yet published. This was just presented at ASCO and showing that, unfortunately, it was negative. Adding nivolumab to concurrent chemoradiation did not improve path complete response, showing essentially the same difference, no differences adding nivolumab. Which actually now we know, because actually if you look at all the studies, whether it's head and neck cancer, lung cancer, esophageal cancer, adding immunotherapy with concurrent chemoradiation does not improve outcome, suggesting that because the radiation essentially kills off any kind of immune activation that you get with immunotherapy. So really the only benefit you get is actually just you do the radiation first and give the immunotherapy afterwards, then you see the benefit. So you don't want to kill off any potential activation of immune cells with the radiation, and therefore that's the reason why this trial is negative. But still, this current standard of care, still, if you're going to do cross, you're going to do adding immunotherapy right after surgery. So that's really the current standard of care, which is not seen in the ESOPEC. So now the question is, for the FLOT trial, should we add immunotherapy, right? The FLOT is just chemotherapy. So should we add immunotherapy to chemotherapy? Well, there's a number of studies now trying to test that question, and unfortunately, actually, all those are negative. So this is a Keynote 585, adding concurrent pembrolizumab to chemotherapy, whether cisplatin-5 or FLOT, and actually there was no difference, no benefit of adding immunotherapy to chemotherapy. Attraction-5 is actually another study adding nivolumab to chemotherapy, showing no benefit of actually adding immunotherapy to chemotherapy. And the Matterhorn study is actually a study that's not yet completed, essentially trying to also ask the question whether you're adding atezolizumab or durvalumab to FLOT will improve outcome. So really showing that immunotherapy to chemotherapy does not necessarily improve outcome. So the only thing that improves outcome right now is actually adding immunotherapy to chemoradiation. So that begs the question, right? So which one is still superior? Well, I think, at least as a radiation oncologist, I believe chemoradiation is still the most optimal management of these patients. Well, overall survival may not be improved. And I don't believe in the ESOPEC trial. I think the ESOPEC trial has a lot of limitation at this point. So I think overall survival may not be improved, but you have to look at new agents. You have to look at the top year studies. However, neoadjuvant chemoradiation may have some benefit. And the reason why is neoadjuvant chemoradiation improves arzor resectability, okay? And that potentially can improve curable resections. And also allows the use of adjuvant nivolumab, which of course the chemotherapy does not seem to show benefit. We know neoadjuvant chemoradiation benefits both adenocarcinoma as well as squamous cell carcinoma, whereas the chemotherapy only benefits adenocarcinoma and does not benefit the squamous cell carcinoma patients. And probably the third reason, and also the most important reason, is that chemoradiation enables organ preservation. Because you don't cure patients with chemotherapy. You only cure patients with chemoradiation, right? So about a third, 25% to 30% of the patients will be cured just with chemoradiation alone without the need for surgery. The reason why is because these patients will have complete response. If they have a complete response, surgery does not add anything to the treatment, right? Surgery only adds complications. Of course, what's the mortality rate of surgery? 2 to 4% in a high volume center. Of course, if you look at European studies, it's up to 10% mortality after surgery, right? In the U.S., MD Anderson, Sloan Kettering, if you look at our survival, 90-day mortality is 2 to 4%, right? That's a mortality rate you don't need to do if the patient had a complete response already cured from your chemoradiation. So a lot of our patients, you don't need surgery. You just need chemoradiation. So now, which is actually what's the most important, we need to select patients, right, who can benefit just with chemoradiation alone without surgery. And of course, that's some of my research and a lot of people's research, trying to understand who can identify who will benefit just with chemoradiation. And there's a lot of markers, both ctDNA, which my lab does, and also there's actually a lot of markers, both imaging as well as tumor markers. You can predict which patients will have complete response to chemoradiation and which patient will have residual disease without distant metastatic disease. And these patients are the ones that actually you need to actually do surgery. So really, this is the holy grail, right? Is that you can cure 25% of these patients with chemoradiation alone, which we know from RTOG 8501. There's a group of patients, about 30, with just surgery alone, you can cure 5-year survival. But then there's about 45% 5-year survival. It improves multimodality management, whether it's chemoradiation or esophageal, right? You do improve, about 15% improvement in survival compared to surgery alone. But there's about a 40% of patients you never cure with any therapy because these patients already have distant metastatic disease. These patients you will not benefit from any local treatment. It's because these patients already have metastatic disease. So what it tells you is that these patients need treatment intensification, and you need to have a way to identify these patients first so that you can actually either give more intense chemotherapy to improve the outcomes for these patients. But of course, the most important is actually that there's a group of patients where organ preservation is possible, right? That you don't need surgery for this group of patients. So is organ preservation possible? I think so. Is that, again, cured with chemoradiation alone? And then there's a group of patients where they don't have distant metastatic disease. They only have local residual disease after chemoradiation. These patients only will benefit from surgery. But there's a group of patients, about 40%, they have distant metastatic disease where you really need to intensify therapy. So really, how do you improve outcomes for these patients? You need to have better ways, right, to assess their local response, whether these patients will have a complete response with your chemoradiation or not, right? And secondly, you have a much better way to determine whether patient had metastatic disease. So therefore, there's ways to do that, which is ctDNA, to identify which patient had minimum residual disease after treatment. And these are the patients you need to actually add additional therapy to try to reduce the amount of metastatic disease these patients may have. All right. So how do we have better local response? And so therefore, the Europeans, and this is from the Netherlands, where they actually trying to see how can we assess which patient had residual disease and which patients will benefit from surgery, right? And so therefore, they have done a pre-senile study. And this study, what they did was they actually did, after chemoradiation, they went back to the tumor and did a biopsy, but they did another biopsy called bite-on-bite biopsy, trying to go deep into the area to see, are there potential residual disease that's underneath? So if you do an initial bite, you probably just look at the superficial area. But if you do additional bite, you might get to the residual disease, which is kind of embedded. And what they found is that from this pre-senile study that was published in Lancet Oncology, showing that actually compared to just one bite, the diagnostic accuracy is improved. So therefore, however, it's not that much better. It's only about 10%. But it's still better than just one bite. So they actually already just took this and they developed the senile study, okay? What the senile study was, which was just published actually last week in Lancet Oncology, what they did was patient were treated with cross, and then in patients, they on bite, in patients without residual disease, what they call a clinical complete response, just based on the biopsy, in patients without residual disease, they randomized them. But of course, patient with residual disease, they had esophagectomy, okay? But the patient without any residual disease, they randomized them to just survey, don't do surgery, versus upfront esophagectomy. If you actually look at the results, no difference. So actually, if you just determine which patient had a complete response after chemoradiation, you don't need to do surgery because the outcomes are identical, whether you do surgery or not, right? Suggesting that just a way to predict which patient had complete response, you can essentially watch these patients to spare their organs, spare their esophagus, and this can substantially improve their quality of life over time, right? Esophagectomy is a big surgery, and it has a lot of morbidity, including mortality, right? So this is a potential way to identify patients that can just be treated with chemoradiation alone. So I think in conclusion for this first part for resectable patients, I think right now we're at a time where there's two options for these patients with locally advanced disease who are resectable disease, either neoadjuvant chemotherapy or neoadjuvant chemoradiation. Although I think a lot of patients with adenocarcinoma are undergoing chemotherapy instead of chemoradiation. What we know, of course, neoadjuvant chemoradiation does enhance complete pathologic response, and therefore potential for organ preservation. I think that's important. Postoperative immunotherapy after chemoradiation has only been proven after chemoradiation, but not after chemotherapy, so that's not another benefit of chemoradiation. And then that neoadjuvant chemotherapy is not optimal for squamous cell, but it's only for adenocarcinoma patients. So really in the future, the benefit is whether actually neoadjuvant chemoradiation followed by immunotherapy or neoadjuvant chemotherapy and with immunotherapy will be superior. So I think these are still studies that needs to be done to compare head-to-head which one's better, right, at incorporating immunotherapy. And so I think this is still ongoing research that we need to do. All right. So I'm going to spend the last part of my talk on patients with unresectable disease, because this is another important area, especially as radiation oncologists. Okay. So because of these patients we're going to see, right? These are patients who cannot go to surgery because of their age or they have more comorbidities, where chemoradiation is the standard of care. We know that chemoradiation is the standard of care because of this very old study, right? There's RTOG 8501, where they randomized patients to 64 gray radiation alone versus 50 gray with concurrent chemotherapy. For you to see here, with radiation alone, there was no patients were cured. None of these patients were cured. However, you get about a quarter of the patients are cured with chemoradiation, okay? But the problem is, why 50 gray only, right? Because we know for esophagus, the standard dose right now is only 50 gray. The local regional control is only 50%, okay? We know that, right? Because remember, 25% or so have complete response. So overall, local regional control is only 50%. But if you look at head and neck cancer, lung cancer, other cancers, we use much higher doses, 64 to 80 gray in prostate cancer. The local regional control is much better, right? So it's very easy. So it's logical to think that, well, maybe we just increase the dose. Why don't we just increase the dose? And that should benefit these patients, right? Well, that's exactly the question, right? So therefore, there's been this old study. Okay, this is intergroup 0122 or 9405, RTOG 9405, which asked the question whether adding dose escalation above 50 gray will improve outcomes. So both of these arms with concurrent chemotherapy, but asking the question between 50 gray and 64.8 gray. This very old study, which is a negative trial, right? If you actually look at this, is that in the patient that received higher doses, there was more deaths, particularly grade 5 toxicity, in patients who received 64.8 gray. But unfortunately, this is kind of a bad luck, unfortunately, because 7 of the 11 deaths occurred before even reaching 50 gray, right? So this is essentially just kind of the luck of the draw, unfortunately. And most of these patients, because at that time, this is a very old study, so they would treat big fields and probably APPA radiation. So probably lots of these patients die from cardiac toxicities and lung toxicities. And so you can see here is that really old techniques. If you look at this arm, this is the kind of the higher dose arm. So it's not better, if not worse. Caveats is really old techniques. I think it's really bad luck, unfortunately, as well. So we really need modern trials. So there's really 3 modern trials that are trying to ask the question of dose escalation, right? So there's a Chinese phase 3 trial, all squamous cell carcinoma patients. The ART-DECO, which is from the Netherlands, 2/3 of squamous cell carcinoma, and the Concord trial. So I'm going to go over these trials right now. All right. So this is a phase 3 randomized trial done in China, where they test the question of their standard care. So their standard dose, 60 gray, with concurrent chemotherapy. They asked the question, this is their experimental arm of 50 gray, because they said in the Western Hemisphere, in America and other places, 50 gray is our standard, right? So they want to ask the question whether 60 gray will be superior than 50 gray. So if you actually look at this is their table. If you actually look at the 50 gray arm, which is their experimental arm, it's actually, the tumors tend to be larger. There's a trend to significance, and also the stage seems to be a little bit worse, even the 50 gray arm. But then actually, if you look at the outcomes, there was 0 benefit of dose escalation. So they're essentially, the 50 gray is identical to their 60 gray, both in overall survival and progression-free survival, including local control. No benefit of dose escalation. But the only thing that was different was toxicity. So if you look at across the different toxicities, the only thing that was significant was pneumonitis. And actually, you see here in the 60 gray arm, there was higher grade 5 toxicity of pneumonitis in the 60 gray arm compared to the 50 gray arm. So their conclusion is actually 50 gray should be the standard of care, not 60 gray, actually. So this is an ART-DECO trial. This is done in the Netherlands, okay? And so they asked the question, they randomized to their cross, which is, they're not really cross, actually. Remember, this is definitive chemoradiation. So they under 50.4 gray, which is the standard of care for patients who don't have, who are not going to go to surgery. But then also they did a boost up to 61.6 gray. Their primary design is actually, primary objective is to improve local control with 15%, so from 50% to 65%, and they were powered to show with 80% power to show a significant difference. No difference in the 2 arms, so these 2 arms are well balanced, with 1/3 of the patients with adenocarcinoma and 2/3 are squamous cell carcinoma patients. So this was published a few years ago now in JCO. No difference in the 2 groups, with a slight, maybe a hint of benefit with the high dose arm, but no difference in p-value of 0.24. what's important is actually the overall survival, no difference in the overall survival between the high dose and the low dose. Actually, the higher dose arm in the overall survival seems to be worse compared to the standard arm. And actually, this is also no difference by histology, whether you look at squamous cells. Squamous tend to do better compared to the adenocarcinoma groups. But then also, if you actually even spread them out, stratify them by histology, no difference in doses regardless of the histology as well. But what's different is toxicities again. If you actually look at the two groups, the boost arm, the higher dose arm, what's significantly, well, not significant, numerically different is that it tend to be higher grade 4 or 5 toxicities in the higher dose arm compared to the lower dose arm. So now the next one is the Concord. This is not yet published, and I've been looking at just even last night. This is not yet been published. However, it was presented at ASTRO 2021. So this patient characteristics between two groups, actually most of these patients are squamous cell carcinoma. 80% are squamous cell carcinoma patients. Here, actually 80, even more, 88% are squamous cell carcinoma patients with locally advanced disease. So the randomization is 66 gray versus 50 gray. So the experimental arm is 66 gray. Again, the p-values are not significant, but numerically, again, worse. Worse toxicity, particularly grade 3 to 5 toxicity in the 66 gray arm compared to 50 gray arm. But no difference in local regional control, no difference in local regional progression-free survival, no difference in overall survival, again, worse in the higher dose arm here in the overall survival. And the causes of death, again, numerically higher in the experimental group for both pulmonary as well as cardiac toxicities. So now, actually the question, is there a role for dose escalation? No, right? No role. 50 gray is the absolute. That's the standard of care, okay? Should be the standard of care. I know as radiation oncologists, we really like to push it, right? But really, there's no evidence for a benefit above 50 gray. So I think in patients who are going to go surgery, 40 gray I think is optimal. But if in patients who you're not sure whether the patient will go to surgery, you just take the 50 gray and you can stop there. So what we do is actually every one of our patients go to 50 gray. That's our standard. And then we have selective surgery. We determine whether the patient had a complete response. Everybody gets a PET after chemoradiation. Everybody gets a biopsies to determine whether they have a clinical response. And then we watch. For patients with clinical response, we observe them. Patients without a complete response, we go to surgery. Very similar to the SANO trial, how the SANO trials do. All right. Now, after chemoradiation, is there a role for surgery? Well, everybody thinks, preoperative chemoradiation, right? Everybody should get surgery. But has there been evidence to show that surgery adds anything to chemoradiation? Well, there's actually 2 phase 3 randomized trials testing this question. So this is a very old study, okay, very old study. All right, so this needs to be repeated. So this is a German study asking the question, chemoradiation alone versus preoperative chemoradiation. So that means chemoradiation followed by surgery. Arm 1 is that patient who got induction chemo. They had chemoradiation followed by surgery versus just chemoradiation alone, okay? This is a little bit weird study. They actually did kind of a variety of chemoradiation. That means patients with larger tumors, they got a boost. They still believe in a boost at that time, right? Because we don't have evidence, very good evidence to show there's no benefit of boost. So they're adding a boost radiation to patients with residual disease. But if you actually look at this, there was no survival benefit adding surgery. The only benefit was actually local regional control, which we expect, right? Surgery does improve local control. But if you actually look at the survival, there was no benefit, no significant benefit of adding surgery to chemoradiation. But one of the things, of course, is that if you look at treatment-related mortality, was much higher. So that means it was 12% 90-day mortality in patients who got chemoradiation surgery versus just chemoradiation. Of course, chemoradiation, not too many patients die from chemoradiation, only 3.5%. So I think, of course, if you can improve the post-operative mortality, probably there would have been a significant survival benefit. Okay. So the second trial was a French trial. Okay, very similar, published around the same time. So this is a little bit different design. Patients were treated with chemoradiation, standard chemoradiation, but then they also had, after 46 gray, they had a workup for a week to determine whether they have patient with progression, things like that. Patient without evidence of progression, then they randomized to surgery versus continuation of chemoradiation. That means from 46 gray to 66 gray. Again, it's still thinking that boost might help, right? So they added additional dose. No difference in overall survival. So adding the surgery seems to not benefit these patients at all. Again, however, I think that a reason why for this is because the 3-month mortality rate is much higher in the surgery alone. It's 9%, 90-day mortality, compared to only about 1% in patients who just received chemoradiation. Again, suggesting that if you can reduce this number to 2 to 4%, then probably there would have been survival benefit of these two groups. All right. So in conclusion, so this is for unresectable disease. Definitive chemoradiation, of course, is a standard of care. 41 gray to 50 gray is really the standard dose range. Higher dose above that is not better, okay, especially above 50 gray. And that because both pathologic complete response is the same, okay, whether you actually go higher than that. So while there is no clear overall survival benefit for surgery after chemoradiation, but I think because the post-op mortality rate was so high in those trials, we still believe that local regional control can be benefited from surgery. So in a patient who needs surgery, especially patient with residual disease after chemoradiation, these patients should go to surgery because that's the only way you can salvage and save these patients, right? But you got to determine that, right? Not every patient should get surgery, or not every patient should not get surgery. You need to select which group of patients should get surgery using these type of approaches, okay? So at MD Anderson, we take a more selective approach again. Based on the patient's preference, age, as well as comorbidities, we determine whether the patient have surgery or not, and determine the optimal therapy afterwards. That's my talk. All right. Do you guys have any questions? Who are the physicians here? Oh, yeah.
Thank you for the excellent talk. I have a question about the radiation field. I think there is some controversy about whether elective node irradiation is needed in esophageal cancer. I wonder what your approach in MD Anderson for the elective nodal irradiation, and particularly in the era of immunotherapy.
Good, very, very important, actually. So we still do we don't do elective nodal radiation, essentially. We do but our margin is still not just tumor plus a small margin. I think the Chinese tried to do that, right? There was a trial that actually used a much smaller margin. It seems like looks pretty good, the results. It has not been repeated by other groups, so we don't know. We don't take that approach. We still want to actually still use a margin. That means because, especially if we're going to consider surgery for a lot of these patients, the benefit of the chemoradiation is really the arzo resection, right? Because what the surgeons do, of course, they don't cut through the tumor. They want to cut above the area that we treated, but usually with the margin they use, actually, it's much, much bigger, right? And they want to actually make sure to have an arzo resection. So what we do is, of course, to ensure that our margin is about 3 centimeters above the tumor. So we determine and delineate the GTV. And then so our superior margin is about 3 cm, 3.5 cm above. So our CTV is about 3.5 cm above the GTV. And of course, including the inferior portion as well. The nodal radiation, particularly, of course, in patients with distal tumors, we only irradiate the celiac axis if patients have N-positive disease. So if patient any nodal positivity, we actually treat the celiac lymph nodes as well as the left gastric lymph nodes, because that's the first echelon of nodes that the disease will recur. But in patients with N0 disease, a lot of patients with just T plus N0s, these patients, we don't do elective nodal radiation. We don't treat the celiacs. Yeah, and we look at our analysis, our data at MD Anderson, and if you take this selective approach, that patient with N0 disease, the celiac axis recurrence is only about 4%, 2 to 4%. And if you leave it out, it doesn't increase the recurrence rate. So therefore, we take that approach. And that's the guidelines, actually, we put in the RTOG guidelines as well. Yeah.
And so for the supracleft nodes, do you also do not irradiate the supracleft if there is N0 disease?
That's right, we don't do that. So, because most of our diseases are actually distal, right? Because adenocarcinoma. But in a patient with squamous, and so nowadays we see a lot more squamous now because of the esophageal in the last 6 months, actually. A lot of patients that come to chemoradiation are the squamous carcinoma patients, and they present with, let's say, mid to upper thoracic tumors. So these patients, we consider bilateral supracleft if they have N-positive disease. Yeah, we radiate their bilateral supracleft.
But no if N0?
That's right. We don't do lymph node radiation. Yeah.
Okay, thank
Yeah.
you.
Mhm. Do you guys do, I don't know, because you guys see a lot of squamous here, carcinoma patients, right? So you probably do chemoradiation, but do you guys do preoperative chemoradiation for squames as well? Or is it mostly just for patients with distal squames? Or even considered like for mid to upper, are you guys doing preoperative or definitive? Preoperative, so you still try to do surgery or consider surgery for these patients?
Most patients still get surgery.
Mm.
Even with clinical CR, our surgeons
Still wants to take them out, huh?
still wants to take them out.
They should do the selective approach again, right? Because actually, if you look at this, right, if you look at, I mean, you probably can evaluate. I mean, it's nice that actually you get to do preoperative chemoradiation. If you look at the surgical specimens, most of these patients, a lot of these patients had complete response, right? So what does surgery add? Nothing. They just added a cosmetic stuff, right? It's like bad quality of life. They had an esophagectomy, right? So they changed the life forever, pretty much, right? It adds nothing, added nothing to chemoradiation. It gave you some assurance. Oh, okay, patient had complete response. Good.
Much confidence about the clinical CR, I think.
Yeah, it will improve. It will improve. There's actually a lot of efforts, of course. You know, the SANO is the first of the study. But actually before that, if you just do standard imaging with PET and biopsy, it is actually it's pretty good. It's not that good. So even the old methods, and that's our, the RTOG 0246, which was published many years ago, actually, JTO 2009. So that was the MD Anderson approach, but it was at the RTOG level. And we did the selective approach in terms of watchful waiting after chemoradiation, and of course, patient with a complete clinical response, just with PET and biopsies. And the survival in patient who had a selective, that means you just watch them with chemoradiation, versus a patient who had clinical incomplete response, that means he had residual disease followed by surgery, there was like no difference in outcome, absolutely no difference in survival. Yeah. So again, adding surgery does not benefit. Okay. I was like, someone's talking. Okay. Yeah. So we need to convince our surgeons, and I think the SANO trial is the first of many studies. Actually, I have another slide deck, which I can practically, if I had more time, I would give another lecture actually on that, on organ preservation. But there's actually quite a lot of studies out there now. So not just SANO's first, but there's actually probably over 10 trials now see if organ preservation will be possible. And a lot of these trials has been completed. There's actually a SANO 3 trial already that's ongoing now. A SANO 3, I don't know if you guys know what the SANO 3 is. Very similar cross, but then in patients who had a complete clinical response based on bite-on-bite, they get randomized to immunotherapy. Basically, whether adding immunotherapy in patients who had a clinical CR will benefit from additional systemic therapy. A lot of patients now are actually getting FLOT upfront, followed by cross, because you want to improve organ preservation. Why ESOPEC if there's going to be a benefit? Or I would say probably still, I don't think there's a benefit based on many caveats. But the reason why ESOPEC will potential benefit is the distant metastatic disease, because it's high-dose chemotherapy. Whereas the cross, there's no high-dose chemotherapy, right? So you still there's about a 40% of patients or 50% of patients will have distant metastatic disease. So that's why there's actually about a handful, maybe about 6 trials now asking the question, can you do induction, FLOT, ×4, then cross, then watch? So that's to basically try to improve organ preservation. You just don't do surgery. And it's like rectal cancer, right? Rectal cancer now, organ preservation is like the thing. We're about a decade behind rectal cancers, but esophageal cancer will need to get there too. Yeah. Thank you, guys.
It's an excellent talk. I have a question curious about the previous study like a couple of years ago for SIP, esophageal cancer. I think it's the phase 1 of 2 trial.
Yeah.
In the Andy Anderson.
Yeah. Yeah. Jim Walsh.
Yeah. I remember that they have overall survival benefit and local control for the SIP group. What's your opinion about it?
Yeah, we don't use it. Yeah, because again, that comparison was a historical comparison, right? And I don't know. Actually, I don't know whether adenocarcinoma will benefit, because actually the thing is about that trial, and you can't really compare to the dose escalation trial. Is not exactly, because that approach was using hypofractionated radiation. It was 2.12, right, gray. So it's not exactly 1.8 gray. So whether hypofractionation will improve the local control is still not yet tested adequately. So you really need a randomized trial. That was a single arm study, and they just compared to historical control. So compared to historical control, there's some limitation to that. Also, another aspect of that dose escalation is that it does not benefit the squamous. So if you actually look at the details. So that group didn't. So if you look at the breakdown of the histology, although it's a smaller group, the dose escalation, there was no benefit of squamous cell carcinoma patients. Only the adenocarcinoma patient benefited from the dose escalation. But we're not sure yet. Yeah. But we don't do it. We still don't do that. Yeah. Although it's the MD Anderson study. Okay. Thank you, guys.